Thanks, Seth. Hello, everyone. My name is Christopher Rodman. I have a background working in inpatient clinical psychology with individuals with substance use disorders. I've worked on Capitol Hill shaping opioid policy, and I have now transitioned to working with CPWR, the Center for Construction Research and Training, on their opioid-related projects. I'm going to be talking today about how construction workers are more likely to die of an opioid overdose, discuss some of the reasons construction workers are at risk, talk about some work-based solutions to the problem, and share some of CPWR's resources with you. So first, what's the problem? We are in an opioid epidemic where 60,000 people died of an opioid-related overdose in the year ending July 2020. That's a nearly 30% increase over the previous year. Unfortunately, preliminary numbers suggest that this number will increase due to the pandemic and other factors. Unfortunately, construction workers seem to be at high risk for opioid overdose. Separate studies in both Massachusetts and Ohio have shown that construction workers were about 7 times more likely to die of an opioid-related overdose than other workers. So what might be some of the reasons for this? Studies have shown that over 1/3 of construction workers report high rates of chronic back pain. In workers over 50, this number is even higher. Construction workers do experience injuries, and a recent study from CPWR showed not only that workers with an injury are more likely to be prescribed an opioid by 3 times, but that injuries also appear to be undercounted. In construction, there can be a desire to get people back to work as quickly as possible after an injury by eliminating the pain of the injury. When a construction worker goes to the doctor, they are more likely to receive an opioid compared to another worker, even for the same type of injury. So this is an industry where high risk for pain and injuries equals high risk for painkillers. Health insurance companies and doctors are willing to write scripts for opioids. And unfortunately, pharma companies marketed opioids to construction workers while playing down the risks and exaggerating the benefits. Finally, the boom-bust cycle of construction can contribute to this as well, because long days and weeks of work without enough rest time or sick days can exacerbate old injuries or make new ones harder to heal. So what are some of the solutions? There are 3 levels of prevention in the public health model. Today, we will talk about the first 2. 1, you deserve to work in a safe environment. Reducing and eliminating the risk factors, including tasks or conditions that cause pain, is the first line of defense. Level 2 prevention includes the care a worker receives when injured. We encourage talking to your doctor about non-opioid interventions that can be used in the case of an injury or pain. Lastly, level 3 prevention refers to workers who are already dependent on opioids. We know that they need help, and medical intervention is best in this case. In regards to level 1 prevention, what are some examples of ways to prevent painful injuries on construction job sites? First, we need ergonomically designed tools, safety and health committees to identify and address hazards. Hazards need to be reported when seen. Housekeeping can prevent slips, trips, and falls. And we need a positive safety culture and program on site. Remember that ergonomics means fitting the task to the worker to prevent musculoskeletal injuries. This can include lifts or assists that are designed to reduce mechanical stress on the worker. Level 2 prevention includes appropriate non-opioid care for individuals who are injured. Studies show that opioids aren't effective painkillers for long-term chronic pain. Therefore, we need to avoid long-term prescriptions, avoid combinations of prescriptions, and advocate for good care, including non-opioid treatment. The bottom line is that pain and injury is a medical issue. There is strong evidence that physical therapy and steroid injections are more effective than opioids for controlling chronic pain. It has been shown that opioids didn't work as well as Tylenol and ibuprofen in studies that looked at dental pain, pain after accidents, post-surgical pain, severe pain from kidney stones, back pain, and other chronic pain. And of course, we know that opioids can cause tremendous harm. The graph to the right shows that the longer the initial prescription for opioids, the higher the chance someone has of being on them for an extended period of time. You can see that this risk really starts at as little as 4 to 5 days and begins to jump after 10 days. Anyone who is given an opioid can become dependent. So it is important to note that addiction refers to the negative behaviors that one engages in order to gain access to opioids, in order to get high or to avoid withdrawals. For individuals who have long-term prescriptions, they are dependent because they would go into withdrawal if the prescription were stopped. At this point, they are at great risk for addiction. If a physician were to stop them without slowly weaning them off the drug, they would immediately begin to experience very unpleasant, uncomfortable withdrawal symptoms. At this point, they'd be more likely to illegally obtain opioids, and the relief that one gets from stopping the withdrawal symptoms is such a powerful reward that dependence can easily become addiction at this point, and those behaviors can continue. The bottom line is that exposure equals greater risk. Exposure to opioids equals greater risk. So let's talk about some of CPWR's resources. You can go to cpwr.com and search opioids. The first hit will be our opioids resource page. These include a toolbox talk, key findings from research, a hazard alert, the physician's alert that was featured on a previous slide, data reports, and links to our opioid awareness program. Finally, if you or someone you know is in need of treatment, you can Google the SAMHSA Treatment Finder, and you will see pages for the SAMHSA helpline and a very useful treatment finder tool that can be searched by geographic location, level of treatment needed, and by your insurance provider's coverage. So that wraps up my talk for today. I would be happy to take any questions. And if you are if interested in hearing more about what CPWR is doing, any of our resources, feel free to email me. I am more than happy to respond. And Seth, thanks so much for the opportunity to be here. I really appreciate it.